I'm Helen, I'm an ST5 in Cardiff and Vale, and I've been involved in the writing of the airway management in patients with suspected or confirmed cervical spine injuries, guidelines which came out just towards the end of last year. I've got no conflicts of interest that I need to declare, and this is the paper that I'm essentially going to talk about. It was a guideline from the Difficult Airway Society, the Association of Anaesthetists, the British Society of Orthopaedic Anaesthetists, ICS, Neuroanaesthetists and Critical Care Society, Faculty of Pre-Hospital Care and Royal College of Emergency Medicine. It was a project that was headed up by Matt Wiles, who's the editor-in-chief of Anaesthesia Journal, and scientifically led by Karim El-Bogdadli, who's a consultant anaesthetist in London. It was felt that these guidelines were needed because there's such a spectre of blame and significant medical legal consequences that occur in anaesthesia. There's so many new techniques available now, and there's, particularly with cervical spine injury management, there was a huge amount of dogma propagation going on. So when you consider cervical spine injuries, there's an incidence of about 15 to 20 per million. About 2% are a fracture without cord injury, about 0.8% are unstable, and about 0.8% of those have a cord injury, with significant risk factors being low GCS and head injuries. And if you look at the diagram on the right, what you can see is actually the type of injuries that, or type of patients we see coming in with cervical spine injuries are changing. So previously in the 1990s, what we saw was it was more younger people, 16 to 50 coming in, usually following RTCs, whereas now we've seen in between the around 2010-ish, we've seen kind of a changeover now to a predominance of silver trauma, and those over 50, being the primary cohort that we're seeing with C-spine injuries. So these are all the stakeholders that were involved. They all had representatives on the group, and as you can imagine, trying to organise one group is quite difficult. Trying to organise 9 groups is even more difficult. And in terms of methodology, we used best practice guidelines methodology. So this is a slightly boring slide, so bear with me, and then I'll get to some slightly more interesting things. But it is important to recognise that these guidelines were written by a multidisciplinary group, which included not just anaesthetists, but ED representation, ITU, pre-hospital, military. We also had ODPs represented, and we had a patient representative. We used the Agreed 2.0 checklist, which is the gold standard for guidelines writing, and adhered to it. And in order to be objective in the recommendations that were made, we did a systematic review, which was prospectively registered on Prospero. That systematic review returned 3,500 papers, which were all screened on title and abstract, and we extracted data from about 350 to 400 papers. Which was then used to inform the recommendations that we made. Experience was used, experience of the group was taken into account when we did the recommendations, which were ratified using a Delphi study. So we did a 3-stage Delphi study with 2 blinded virtual rounds and a final round table. And then all of the recommendations made were qualified based on the strength of evidence, and they were graded A to D, which you can see based on the table on the right. So grade A, recommendation with grade A evidence is something that's got consistent RCTs and meta-analyses of systematic reviews, all the way down to expert opinion, which is D. And the significant limitations in the evidence, we heard about in the last talk about the limitations in terms of steroid replacement, but actually in terms of C-spine injury, there was really, really significant limitations in the evidence that was available. And that was in multiple different facets, really. But the primary outcome that we were interested in was the space available for cord. So the space available for cord is between your ligaments. If you're going to end up with an internal cervical spine injury, that's the space that matters, essentially. And what we wanted to see was what studies were out there that actually measured space available for cord. And the reality is there was very, very few. Most of the studies were also conducted in either cadavers or healthy volunteers who'd had a cervical collar put on. Limitations in that being, I like to think most people here will take the cervical collar off before trying to tube somebody. And actually in the cadavers, the cervical spine injuries given to the cadavers prior to intubation were so severe that actually a lot of them aren't compatible with life. So those patients wouldn't even make it into the into resus. So really, really big limitations in terms of those three key factors, but also a lack of neurological follow-up. And the primary outcome in most of the studies was best glottic view. However, there are some good studies out there, and one of the best ones that we found was this one by Shotekar et al. In 2020. So it compared use of air track and fibre optic intubation in patients with unstable cervical spine fractures, and it was a neurophysiological study. It had 40 patients and it looked at SSEPs monitored during 4 stages. So before airway management as a baseline, during face mask ventilation, and after definitive positioning for surgery. And what it found was that there was significant neurophysiological modifications detected during 2 patients at intubation, 1 during face mask ventilation, but 13 during positioning. And that, I don't know if it's your experience, but it's definitely my experience, is it kind of lines up with, you know, we spend all of this time being super careful intubating the patient, and then you hand over to the surgeons to position them and get them in pins, and then you just see them apparently moving them everywhere. But actually, really importantly, none of the patients had a worsening of their neurological status at discharge. So overall, this was felt to be one of the best studies out there because it had the right cohort, and actually it measured something that was important in terms of neurological status and function. We also looked at the risk of tracheal intubation during intubation of those with spinal cord injuries. And we looked at the NHS litigation analysis between 2008 and 2018. In total, there is 10,673 claims. Around 1,230 of those were related to anaesthesia, worth approximately 93 million in total. But none of them were to do with cases of secondary spinal cord injury after tracheal intubation, which was reassuring. So going back to the guidelines, they make a number of different recommendations, and we've broken them down into the different sections of airway management. So thinking about pre-oxygenation and face mask ventilation, what we found was that actually face mask ventilation is the airway maneuver which causes the most cervical spine movement. So with that in mind, the recommendations were to attempt to minimize that movement during pre-oxygenation and face mask ventilation as much as possible. When a simple airway maneuver is required, to use a dual thrust rather than a head tilt chin lift. And you can consider using high flow for per-oxygenation, but with caution, because in patients with suspected or confirmed base of skull fractures, there is instances and case reports of pneumocephalus. So while high flow is good, maybe not all the time, and just have it in the back of your mind. Supraglottic airway devices, they should be used according to management needs and not solely for the purpose of reducing head movement in patients with suspected or confirmed injuries. If intubation is required through a supraglottic, there's no specific device that's clearly better, and you should use whatever you're familiar with and is available to you. But generally, second generation supraglottics are preferred to first generation supraglottics. In terms of intubation, the strongest evidence out there is about using video laryngoscopy. So where possible, we suggest you use a VL, but we're unable to recommend a specific VL. And I think that's fair, particularly given the range of VLs are available in different hospitals. And even in our hospital, there's a slight difference in what you get in theatre to what you get in ED. But also, we thought it was important that clinicians were trained to perform VL in patients with a level of immobilization, just because a lot of the time we practice on mannequins, but actually we don't do any kind of immobilization training. Bougies and stylettes, generally these are good. The evidence is that they can help you, so consider using one. And cricoid force. So cricoid force is one of those things that's very much up in the air and a huge topic of debate at the moment. All of the previous studies of cricoid force are have essentially been called into question based on the fact that we have studies now that show, using ultrasound guidance, that people's ability to do cricoid force is very, very poor in terms of localizing the cricoid. So all the evidence that we have on cricoid is questionable in terms of we don't actually know if it's good and we don't know if it's bad. So if you are going to use cricoid force, we suggest that it's carried out by someone who has had training. If there's difficulty in intubating, it should be removed. But if there's a laryngeal injury or you suspect there's a laryngeal injury, you shouldn't use it. You can use a bit of cautious external laryngeal manipulation to help you during intubation. Again, that's slightly easier with a video laryngoscope, as your ODPs can see what they're doing and try and help you get a good view. Awake intubation was previously felt to be the gold standard, but the decision of choosing awake or asleep was actually felt very much to be individualized and should be based on a case-by-case basis, considering things like patient factors, equipment availability, and the proficiency of the clinician with the technique. There's a really big recognition that actually a lot of these intubations happen in recess at 2 o'clock or 3 o'clock in the morning, when you might have a core trainee who's significantly more confident using a video laryngoscope than they are using a flexible bronchoscope. So a little bit of individualized approach in terms of that is recommended, but I wouldn't rule it out, and I would consider it, particularly if you think there are other risk factors that would make it beneficial. One of the, actually probably the biggest controversy in the guidelines is the discussion of Mills. Mills is one of the big dogmas in C-spine, in airway management and C-spine injuries, and actually this was one of the recommendations that, following review of all of the organisations involved, had to be kind of dialed down a little bit and softened. Generally, we say Mills, there's very, very limited evidence for it, particularly that there's particularly very little evidence that it reduces the risk of secondary spinal cord injury. If you do choose to use it, then we would suggest having a very, very low threshold for taking it off, particularly if it's difficult. There is really good evidence out there that Mills makes things more difficult, and I'll talk about that in a second. And the other thing that we recommend during intubation, you take a collar off, or you remove the front part of a semi-rigid collar, which can make things a little bit easier for you. So in terms of Mills, there's a really, really good editorial written by Matt Wiles in Anaesthesia from 2021, summarising the effects of Mills. But essentially, there's really good evidence that use of Mills worsens your laryngeal view, increases your likelihood of a failed intubation, increases the duration of your intubation, increases the forces you apply during laryngoscopy. It provides minimal immobilization of the cervical spine, and there's even evidence that it can increase subluxation of the injured spine. So, in summary, there's a very, very weak evidence base for clinical practice in these patients, which is why most of the recommendations made are based on expert opinion. Using the technique that's best in your hands can help ensure that tracheal intubation is successful and that minimal cervical spine movement occurs and forces are applied. VL is recommended, but direct laryngoscopy is not inferior in terms of cervical spine's protection. Cervical spine injury is not an indication for an awake tracheal intubation on its own, and Mills shouldn't be kept on at the cost of a difficult intubation. So ultimately, remember, the maximum insult to your spinal cord occurs at the time of injury. The optimal technique is the best technique in your hands. Thank you very much.